Call the meeting to order of the Emergency Medical Care Committee for July of 2025.
All right, roll call. Will Hiller.
Here.
Chris Borkin.
Here.
David Sargenti.
Here.
Let's see. We did not receive the information for the BLS representative at this point. Harry Robbins.
Here.
Jody Schaefer. Paul Wood. Marie Lutz. Our paramedic representative is still working through the paperwork. Carla Spencer and John Anthony.
Here.
We have a quorum.
Hey, Steve. This is Lupe. I'm actually present.
Lupe, glad to have you. Okay, so we've done our, oh, Carla's here. Excellent. All right. All right, so membership, alternate members, Mike Esslinger. Mike DeLeo.
Present.
Cheryl Getz. Ben Harvey. Dr. Hawthorne.
I'm here.
Wonderful, thank you. Joe Cafaro. Bandy Smith, nope. All right, ex officio members, Teresa Rios. Here. Leon Magaski. And Kelsey Scanlon. All right, with that, guests, we'll start in the room. If you'd like to announce your presence.
Rachel Nealand Amor.
Ben Hitchcock, Amor.
Justin Reyes, Monterey County Regional Fire.
Stephen Chrisley, Stillings Fire.
All right, EMS agency staff.
Blake Anderson with the EMS agency.
Kimberly Hernandez, EMS Agency.
Karina Moreno, EMS Agency.
And those online who would like to announce their presence.
Dr. Bright, St. Sally State Prison.
Betty Hull, Chief Nurse Executive, CTF.
I'm sorry, who was that?
Betty Hull,
Betty Hull. Thank
HULL, CTF. Thank you.
Grady, thank you, Betty.
I'm Turner, Active Transport.
Oh, wonderful, thank you.
Michelle
Morning.
Kalinsky, Chomp.
Thank you.
Good morning, Joe Cafaro with the Hospital Council. Sorry for joining late.
Great, thank you, Joe.
Jeff Horner here with CalStar.
Jeff, wonderful, thank you.
Jason Sullivan, Seaside Fire.
Jason, thank you very much.
Silas Fisher, Monterey Fire.
Thank you, Silas.
Devin, how you Fort Lincoln Fire?
Devin, got you, thank you.
Lupe Lazama, AMR.
Lupe, thank you.
Susan Duke, Community Hospital.
Susan, thank you. Did I miss anybody? I don't think so. Oh, and our medical director.
John Burley, EMS agency.
Wonderful, thank you. Did I miss anybody? Great, thank you. We appreciate your participation.
Okay, for our next order of business, it will be the election of the chair. So we have,
Nominations.
are there any nominations?
Yes, I'd like to make a motion that Will Hiller for chair and Chris Borkman for vice chair.
I have a motion by Harry and a second by Jody Schaefer. Any other nominations?
Then might want to ask if you're willing to.
As long as requires zero knowledge of the EMS agency on your person. I can manage a meeting, but I don't know any.
It's okay. We'll help you through. Okay, then let's do a roll call vote. Will?
Abstain.
That's it. You do it. Chris? You did. You vote for the motion. We'll go with that. David Sargenti? Harry Robbins?
Aye.
Jody Schaefer? Marie Lutz? Carla Spencer? John Anthony?
Aye.
And motion carries. It's probably, if you'd like, we can do a transfer of.
I'll go sit back in my seat from last year.
Yeah. Thank you all.
All right, so, sorry, just move on.
Approval of the minutes.
All right, so
Or, oh, sorry, public comment.
public comment. So, item number 2, public comment. Any member of the public may address the committee for a period not to exceed 3 minutes on any issue not on the committee's agenda. The EMCC will listen to all communication but may not take action.
See no comments from the public. Anybody online? Hearing none.
All right. Pardon me. Moving on to item 3, approval of past EMCC meeting minutes.
Was made for these meetings.
I'll second it. All right.
Would you like a roll call vote or a voice vote?
Voice vote. Sounds good.
All right, motion to approve the minutes by Harry Robbins, second by John Anthony. All in favor?
Aye.
Opposed or abstentions? Motion carries. Thank you.
All right, moving on to item 4, standing reports. EMS Director Teresa Rios.
Thank you, Will. I have a couple of updates that are their own agenda items, so I'm not going to cover those right now. But just 2 items that I think are of interest to this committee is that we have been working with the data working group on HDE. Now that the 4 hospitals are fully functional on with HDE, and we're starting to wind down on other items. Blake is going to report on that later. We are going to move into a bigger project, a countywide project that we've been wanting to tackle. We had other items to tackle, but we've been wanting to do a data cleanup and a standardization of the PCRs. And it seems like the group that we have right now working on HDE has done such a great job working with us and informing us on issues that come up and whatnot, that we want to continue with that group and move into that bigger data cleanup because it's needed. We've reported to this committee many times that you ask us for data that we have to do a lot of manual work. And each time that we do that, we learn more about what needs to be fixed from knowing that different agencies track things differently because each agency is able to turn on and off buttons individually. Some turn this buttons on, but not those. And so we're not getting standard clean data. Sometimes we have to go in and read the narratives of the reports in order to find the data that we're looking for, which causes us to spend a lot of time getting the reports, the data that we need to be able to report to this body or things that we need just for administration and oversight of the system. So we are putting together our plan to bring to the next meeting, and we'll be reporting to this group as we make progress there. The other item is that we reported some time ago that we wanted to transition from a very clunky way of tracking our EMT and paramedic applications to an actual database. We selected a vendor, but we had issues because we have to work with the auditor controllers to accept the payments. It had been a long process to do that. So we are close to executing the contract. We're pretty close now. And so that's going to make our life not only easier, but more, we're going to be more efficient, and we're going to be able, it should be an easier experience for those submitting their applications to submit their items electronically, and the payments a lot of times, you know, they bring in their applications to us paper packets, and so we want to move to completely electronic way of doing things. Join the current century, if you will. And the other two items are their own agenda, so I'll hold off until those two items come up to give you a report, but I'm happy to answer any questions you may have.
Thank you, Tressa. Moving on to item B, EMS Medical Director, Dr. John Burley.
Thanks, Will. So we just completed our clinical care committee meeting earlier this morning, and just a few items from that. We had a report from Kimberly regarding ambulance patient offload times, that the median APOT time seems to be stable and under the 30-minute threshold. SVH did have a bit of an uptick and is sort of at the cusp of the 30-minute threshold, so we're working with them. But thus far, everyone is within the compliance with the standard. We heard from Blake regarding buprenorphine data. He reminded us that we had had about 30 cases of buprenorphine administration since the implementation of the program in May 2023, which doesn't seem like a whole lot of cases over the course of the last couple of years, but he did point out that half of those cases were in this year alone. And so we've had a nice increase in compliance and administration of buprenorphine this year, and we'd like to keep that momentum going. And the outcomes for those cases were predominantly positive outcomes. We had a report on health data exchange from Blake, but he's going to give us a report, I believe, later this meeting, so I'll leave that to him. Steve had given us a report on the 2025 policy and protocol review cycle, which the new protocols went into effect on July 1, so those are now active. And we'll be working on the 2026 policy and protocol review cycle over the course of the next year. The buprenorphine local optional scope of practice is expiring at the end of this year, but we'll be seeking a renewal of our LOSOP for that, so we can continue the program going. We may end up switching from the strictly buprenorphine to a buprenorphine naloxone combination, which is also known under the brand name of Suboxone. And the reason for this is simply that the accessibility of the films, that the oral films that patients receive, is much more accessible as Suboxone versus just buprenorphine alone. Getting just bu by itself is challenging, and so we're entertaining making a slight adjustment to that. Other than that, we did also hear from Kimberly regarding AB 40 implementation by the state. The state will now be monitoring APOT times and holding hospitals to the local standard. And so data is now going directly through ChemSys to the state. But this is sort of a rapidly evolving notice. We just found out within the last week, and we're working with the state to try to get up to speed, as are all the hospitals. So that's a recent development. I think those were the primary things that we discussed at CCC. I'm happy to entertain any questions that you may have.
Thank you, Dr. Burley. Moving on to item C. Sorry about that. Thank you, Teresa. Moving to item C, MOAC. Sorry.
Deborah's at another meeting, so Kimberly will be providing the report.
Okay, MOAC update. Good morning. So MOAC activities over the past few months have been fairly low key. However, the EMS agency did participate in the county's Nacimiento Functional EOC exercise on May 22nd. During the drill, the MOAC provided support around medical health coordination and communication strategies, which is great practice if there were a real world emergency response scenario. And looking ahead, we anticipate increased activity as planning ramps up for Car Week in August. Any questions? Okay, I'm going to stay up here.
Thank you.
Okay. All right. So let me, hold on, play my agenda real quick. Okay. All right, so first communication system testing, 800 megahertz and ReadyNet testing results are within your agenda packet. As I usually report, the EMS agency receives the results. EMS dispatch conducts the results with the 800 megahertz radio and the ReadyNet because they conduct the drills, because they would use it in an actual MCI if they were using it. And then we receive the results about the 5th of the month, and then we report those to the hospitals and see if there are any, like, if for whatever reason there were responsiveness by the hospital, if there were any issues. Sometimes the radio goes down, sometimes it's unplugged. Different things can cause the compliance to go down. So we continue to do that. Any questions on 800 megahertz or ReadyNet? Okay. Moving on to contract compliance. Again, there is a PowerPoint within your agenda packet on response time compliance. All reportable priorities met or exceeded 90% compliance. We're reporting on April and May for this meeting. With the exception of Orange in priority 1, it was at 89%. We have met with AMR and they identified some things they think contributed to the lower compliance, particularly shoot times. They also switched some of their 24-hour units to a 12-hour, so that will kind of help resolve some of the shoot time delays. So we haven't seen what June's compliance is yet. It's not yet reported, but we'll see how priority 1 and Orange did it for June. Any questions on response time compliance? I think that's it. All right, thank you.
Thank you, Kim. Do we move on to item C, Kim?
Those-
It's not
those
reported,
meetings are
pardon me.
Just certain amounts.
So moving on to
The ordinance revision, which is also on hold.
on hold.
So Blake for health data exchange.
Blake for Health Data Exchange, thank you.
Well, good morning, everybody. So in your packets, you should have received a report on the Health Data Exchange and where we are at in the process. We are glad to say that Me Memorial is now fully operational with Health Data Exchange, so that we are seeing outcome reports from the hospital being sent to the providers. And initially, when this was rolled out on May 13th, we saw kind of a concerning trend where I believe it was 40% of EPCRs were not being matched with an outcome. In our review, we identified two fire agencies that were not receiving outcome reports, and we've since connected with ESO to get that addressed. And as of late, the latest match rate we see with with Me Memorial is 93%, so a significant improvement. And we're going to continue to monitor, but at this time, all hospitals are currently operational with Health Data Exchange. And we'd like to thank all the hospitals for participating and working with us, and with the provider agencies. And we're very happy that we finally have gotten this off the ground. And we're at the point where we're getting to the closing phases of this. We're still going to do some monitoring just to make sure reports are being submitted timely to the hospitals, and that they have access to them and they're appropriately integrated into their systems. But outside of that, does anyone have any questions on the Health Data Exchange?
Obviously, the first big win is that.
Oh, pardon me, yeah.
The first big win is that it's live and everybody's participating. I'm wondering if there are early indications of any training opportunities or policy change opportunities based on the feedback you're getting from the outcome reports.
So I think one of the things we're currently looking at, well, one of the big things I currently use in one of my fields is for the buprenorphine. Because with the buprenorphine project, we meet constantly with not only San Benito County and Santa Cruz County, who are our partners in this project, but we work with our sons, and we wanted to follow the outreach, the work that the providers did, and then the follow-up that the hospitals give as well. And so that has been very helpful for us in identifying how efficiently patients who are being brought in with opioid use disorder into the hospitals, and are they receiving the after-action treatments that they need, and being connected with services for that. So we are monitoring that. It's very helpful for us as we begin to use it in our STEMI, our stroke, and our trauma patients, in our QI meetings that we have. We've been using that to monitor patient outcomes and give feedback. And in some sense, that helps us where we don't have to do the outreach to the hospital and provide that back information. There have been some times too that the information we had, which has previously been submitted to us, releases the hospital to then do sometimes further presentations. And we've seen at some of our QI meetings, some very intensive imaging and further details that we would never get prior. But that's because a lot of hospitals would focus on kind of our basic needs that we requested. Now with the outcome reports, that's kind of relieved them to do kind of what I would say is a little extra. So that those are kind of the biggest takeaways we've had. We're now, one of the projects we will be also working on with the outcome reports is following up on cardiac arrest as well, and seeing how the performance of that. We do participate in CARES as of right now. That does give us some level, but it's a very superficial level and doesn't get too much into details, but we're hoping to utilize that for the CARES program as well.
Thank you.
So,
if I may, I would like to just acknowledge Blake's performance in this project. We have been able to get in the hospitals. Of course, I want to acknowledge everybody who has participated, but I think that Blake has done a really good job shepherding this project and working with all the hospitals and with ESO in getting the issues that have come up resolved as quickly as possible. He's given our stakeholders a very timely response on when they raise a concern, and has held our provider ESO accountable for the mishaps or what is missing in the system. We had not done that in a long time, so I think that now we see this shift is a better working relationship with our vendor, because now they know that they have to respond. They have many customers, of course, but when we need something, they are providing it to us. And there has been a litany of issues that he has raised with ESO, not just with the HDE, but overall. So I think that, thank you, Blake, for all the work that you've done. Thank you for everybody who has participated, the hospitals, a lot of the heavy lifting that was done to get the connections between ESO and the hospital, of course, was between ESO and the hospital's IT team. So we are very appreciative of that. And we're looking forward to seeing more ways in which we can use HDE. Our Epi, I was going to call her HDE, but our epidemiologist is back. She was out on leave. So now that she's back on board, we want to meet with her and Dr. Burley as well, to start looking at, different things that we may want to track, different ways in which we can use the data now. So.
any questions from anyone online? Hearing none, thank you very much.
Thank you, Blake. And I definitely echo Teresa's sentiments about getting the project started. For us at AMR. Having the clinical feedback has assisted with tailoring our annual education, as well as when we do investigations on clinical excellence or areas where we need improvement. It's offered very specific feedback to those crew members. So thank you for that. All right. No, item D, item E. Oh, I'm sorry, item C. Steve.
I can speak to this. This is an item that's brought to us related to our policy 3030 related to the provision of EMD determinant information to all providers, specifically the fire first response. This was brought by Chief Klemick, who has stepped down from being a part of this committee. So as a point of order, I'm going to ask the next person in the position, Chief Sargenti. Would this be something you'd like to see continued to reside here as part of our potential discussion, or what would you like?
I haven't spoken with Chief Clement about his concerns and if they've been addressed. So let me circle back with him and get a good transition, and I can bring something back to you.
Great, thank you. Whatever the will is, we can do. And also Leanne Magoski, has some things in this. So we'll see. Let us know. Thank you.
Thank you, Steve. And item E. EMCC appointment, reappointments.
D.
There's no report for D.
Perfect, that's right. Okay, item E, EMCC appointments, reappointments. At this point, I'd like to welcome some of our new members to the EMCC. We have David Sargenti, who is representing ALS fire departments and districts. He's taking over from Sam Klemick, who's served ably on this committee. We have, pardon me while I get to my notes here. We have Jason Sullins, who's been nominated, well, who's been recommended for BLS fire. We still need a little bit of information from him. I hope we'd have that, be able to take his nomination to the board yesterday, but that did not occur. Carla, you're still current. Paul Wood, you're still current, actively working with some citizen representatives. We have a recommendation for Cameron Silber to be the paramedic representative. He also needs to provide a little bit more information. I'll be reaching out to him. Dr. Lutz, you're still current. Chris Borkin has completed the paperwork and has been appointed by the Board of Supervisors yesterday. So thank you for your continued service. Will Hiller, also nomination taken to the board, and he was appointed yesterday. David Sargenti, as I mentioned, was appointed yesterday. John Anthony, your term's expiring. Need to get something from you. Jody Schaefer, your nomination was to the board, and they appointed you yesterday. And Harry Robbins will figure yours out as we move forward. Those were the members, alternate members. Cheryl Getz remains current as a BLS fire representative. Joe Cafaro remains current as a hospital representative. Noah Hawthorne, we appreciate your continued staying with us so we get another ED physician rep. Steve Adams, who I believe is maybe retiring. So we'll need a alternate for him. See if we can get some citizen representatives to back up our citizen representatives. Paramedics, with Cameron stepping up, that opened up a alternate spot, so we'll be looking for that. Paul Tomasi, need a little more information from him. Okay, congratulations to him, and please let us know as early as possible so we can move that through the board. Mike Esslinger as the alternate for the ambulance contractor. His nomination went through and he was appointed by the board as an alternate. Mike DeLeo for ALS Fire Chiefs is expiring, and as is Bandy Smith. Any questions about membership? That's current status. Hearing none, thank you.
All right, moving to item F, EMCC annual report. Steve.
All right, the EMCC annual report was brought to this body last meeting, and it was endorsed, and we pushing it through for hopefully the next board meeting, which we had hoped would be yesterday, but it will be in August. So we'll let you know when it goes to the board, probably consent item, but we'll make sure you guys know when this goes to the board.
Probably will be August 4th. In July, the board only met the first and second week of July, so yesterday. And then they will meet the rest of the month, so that's why it's being delayed until August.
But we think, again, just to reiterate what was said at the last meeting, there's a lot in there. This body, considered a lot of things, discussed a lot of things, and recommended a lot of, endorsement for a lot of important items. And so from the agency, we thank you, and this report reflects well on this group. So looking forward to getting it to the board in August.
Thank you, Steve. Item G, Teresa.
Thank you. The EMS agency brought the 2024 EMS annual report to the Board of Supervisors at the end of June. This year, we took a different take on the report. Normally, we highlight the data and some of our accomplishments, but we had conversations that, we wanted to do something different and give the Board of Supervisors a different perspective of how the EMS system really works. And Dr. Burley had an idea and took on a major project.
Thanks, Teresa. So essentially what we did was, the idea was, instead of giving a PowerPoint presentation to the board explaining what we do, and we had an idea of presenting a case that looked at all the different steps that we take as an EMS system, from receiving the 911 call to dispatch, to dispatching the units, arriving on the scene, triage, hospitals, intaking patients and managing them all the way through to rehab. And so we thought that it would be interesting to create a video that essentially followed a call that actually occurred here in Monterey County. And that call was an incident that took place down in King City back in March of 2024. It was an MCI involving a drive-by shooting that occurred at a suburban residence. It was actually a birthday party that was going on. There were a bunch of people sort of out on the lawn, including children, and there was a vehicle that drove by and opened fire. And so you probably all remember this incident, but the reason why we chose it was several-fold. One is that it was a complicated response. It really was not, EMS is much more than just getting a 911 call and an ambulance arrives at someone's house and picks them up and takes them to the hospital. An EMS system involves so many different components, and we wanted to sort of impress upon the board the complexity of that system and often the difficulty in managing a challenging situation like this. So this was a case in which, you can't plan for everything, and this is certainly not something we typically would expect to happen or plan for, but you need to be ready when that does happen. And we felt that this particular incident really highlighted how well the system came together and functioned as a cohesive unit during a time of high stress and high stakes. So anyway, I put together this video that it's about 18 minutes or so. And if you're okay with it, I'd like to, go ahead and show it to you. I'm gonna try to share my screen, and I might get a little reverberation back. And if I do, I'll just take my laptop out. We'll continue the meeting, and I'll try it again in a moment or two. But let's see if it works here. Yeah, okay, let's see. So I need to do, yeah,
Leave it there, but whatever your sound is
Yeah.
on your laptop, just mute.
yeah, but I'll need
You
my
have sharing.
microphone, right? Well, I need to do my microphone? No, on here.
Mute.
Okay. So laptop. Muted.
And then. It's there. You just push play.
Will this come on?
You see the play? No, you mute that.
but they can't hear it.
No, there's no sound.
See,
Okay.
so I think I have to just basically play it on here and then hold the microphone up. All right, I'm gonna take this out and I'll just do it from my office.
Okay.
See if it works.
Should we go to the next
Yeah,
item while
go
you do that?
ahead.
All right, so moving on to the next item, EOA ambulance contract, Teresa.
Sorry.
Thank you. I am happy to report that the Board of Supervisors yesterday awarded the contract for ambulance services to AMR. We are excited that we've gotten to this place. We thank all of you. I particularly thank the team because we worked really, really hard on getting to this point. It was a long process, took a long time. And what I would like to do is to have Kimberly go over some of the features of the new agreement. Our next steps are to start immediately in moving to the transition into the new agreement. Along with the proposal that we received from the companies. Well, let me backtrack a little. We received 2 bids. Both were found responsive, and the proposal review panel recommended the award to AMR. As part of their bids, they submitted a transition plan. In addition to that, in the scope of work that we drafted, we identified milestones that need to be reached during the transition. And so for that reason, one of the things that we did is that we made the contract term to include the transition period so that we could work closely with the provider in the implementation of the new contract. So we're going to move into the transition period, but we also what we want to do is schedule some meetings with key stakeholders. Hospitals is a key group that we want to work with, fire agencies and law enforcement, different stakeholders, so that we can go through the contract and explain the different features in more detail, answer questions, clarify language that might not be very clear. But we are hoping that, well, we're not hoping, we know that this contract is going to bring enhancements to the system, including additional unit hours in the system. But I'm going to let Kimberly go over some of that, some of those items. But as you see on this slide, the transition period starts upon execution of the contract, which should be sometime next week, and it'll go through January 31st. And the initial award is from February 2026 to January 31st of 2032. There is an opportunity to extend the contract for up to 5 years, so it could go all the way to 2037. Kimberly, would you like to?
Yes,
Thank
okay,
you.
and I'm gonna stay seated if it's okay, because I'm managing the PowerPoint and some notes. So on this slide, you'll see the agreement maintains key features of the current EMS system. I'm gonna highlight a few of those, but feel free to read through the bullets. First, AMR has over 17 years of continuous service to the county and a management team with extensive local experience. This will maintain working relationships with system stakeholders that are already in place with AMR. Second, the agreement covers emergency 911 interfacility and CCT transports. Third, the ambulance service provider will continue providing dispatch services. The agreement will maintain many of the important ancillary services requirements that are currently in place, and this includes things like providing training, equipment, and supply restock, and purchasing programs for first responder agencies. So EMS system enhancements that are operational, again, I'm going to go through, just highlight some of these. AMR has committed to providing additional weekly ambulance unit hours. This will increase the number of ambulances available in the system and allow them to respond to calls for service in a more timely manner. The agreement permits the implementation of basic life support ambulances staffed by 2 EMTs. The BLS ambulances will be available to handle interfacility transfers appropriate for their level of care, as well as lower acuity calls through the 911 system. The agreement brings about several equipment and technology-related improvements. Primary with these is phased in transition to Type 3 ambulances. This changes from the Type 2 or the van-style ambulance. They're going to be transitioning to the modular box-style ambulance, which is a Type 3. AMR will start the operational period of the agreement with a portion of Type 3 ambulances and then transition the remainder of their fleet as the ambulances are in need of replacement to Type 3 ambulances. EMS system enhancements in the clinical area. Traditionally, ambulance service providers have been judged solely on response time metrics and how quickly they can get an ambulance to a patient. As EMS has grown and progressed, we've realized that the care EMS providers deliver once they arrive and ensuring that they take patients to the right facility capable of treating their specific needs is just as important, if not more so, than response times. The agreement provides for the implementation of a clinical scorecard that will allow the EMS agency to measure and monitor the clinical care that AMR delivers so that we can ensure that patients throughout the county receive appropriate high-quality care. Over the next several months, we're going to work with AMR to establish standards, benchmarks, and goals for the various clinical metrics. Also, the agreement provides expansion of CCT services to include paramedic level providers. While the agreement still requires that AMR provide a nurse on a CCT nurse on a 24/7 basis, and some patients' clinical needs will need this level of care, there's a significant portion of patients who have needs that can be managed by a paramedic with additional training and working under an expanded scope. Much like BLS ambulances help keep ALS ambulances in service for higher acuity patients, the expanded scope paramedic providers will help keep the CCT nurses available for patients who need their specialized care. Additionally, the agreement provides for the implementation of 911 nurse navigation program. The EMS system frequently sees the use of 911 for situations that could be better managed by resources other than an ambulance and transport to an emergency department. This program would allow dispatchers and providers in the field to divert a subset of patients with lower acuity problems to nurses available by phone. The nurse navigator is able to assess the patient's needs and refer the patients to a variety of different care resources available within the community. If the nurse determines a solution for the patient's needs that would require transport to another location, such as a pharmacy or an outpatient care setting, the nurse helps arrange appropriate transportation to the facility. Referral services will be provided without regard to payer or insurance status, and there will be no charge to patients for the use of the referral services. So EMS system enhancements, equity of care. The agreement allows the EMS agency to not only monitor response times in the larger zones, but also look at response times on the community level, ensure there are not pockets of the community receiving a lesser level of service. This level of analysis can be particularly helpful in ensuring that resources are adequately allocated to South and North County to meet response times in the individual communities located there. And if the analysis identifies pockets of inequity, AMR will be expected to take steps to improve their services. We previously covered the implementation of a scorecard looking at the clinical care provided by AMR. The agreement also provides that this data must be disaggregated and reviewed to help ensure that all patients are receiving high quality care regardless of their race, gender, or other statuses. And additionally, the agreement provides for a variety of resources for personnel and patients to enhance the patient's experience and the use of the EMS system. So monitoring and accreditation, AMR has committed to obtaining 3 key accreditation or recognition metrics within 2 years. You'll see them on the screen, the CAAS accreditation within 2 years, ACE accreditation within 2 years, and American Heart Association Mission Lifeline EMS recognition within 2 years. CAAS accreditation looks at a provider's operational programs and practices to ensure that they are meeting best practices and recognized standards. ACE accreditation looks at analogous metrics for AMR's dispatch center and its performance. And the American Heart Association's Mission Lifeline recognition looks at EMS system performance and the care delivered to patients experiencing heart attacks or strokes. The agreement also provides for the implementation of a suite of software to monitor clinical and operational data and programs. This software will allow the EMS agency and AMR to monitor the health and effectiveness of the EMS system on a near real-time basis. It also provides the tools to measure and report on response time and clinical performance metrics. Another important tool of this program will allow AMR to monitor the workloads of their providers in the field so that they can identify the potential for crew fatigue and take steps to alleviate it. Any questions?
There are quite a few improvements. Oh, I'm sorry.
Thank you.
Okay, there are quite a few improvements and enhancements in this package. My question is, what or how do we plan to get this information out to the community at large so that they're aware of what the changes are and particularly what the enhancements are, what they can expect? It seems to me that has got to be a critical element of this implementation process.
So the rollout of implementation notification starts with the key stakeholders. In the last 2-3 years, we have made better use of our social media. And so we will be crafting campaigns, easy to read or easy to access for the members of the public. In my past life, we have done mass mailers to people. We've done radio as well. Those are things that we can also entertain. But it has been our belief for some time that we need to do a better job at educating our community as to what is the EMS system, how it works, and how they can best access or what they can expect when they call 911 and the ambulance shows up.
I attach a considerable amount of importance to this, to the contract. And I was surprised last night, particularly on Channel 8, they didn't have any coverage of the contract approval that I saw. So I'm not sure if any of this has gotten out to the media, and therefore I'm concerned about the education process for the community as a whole.
There was one article that got released. I got the link for it yesterday evening. We'll send it out to everybody just to make sure that everybody gets it. But you're right. Usually we don't get a lot of media attention unless things are not going right. Then we don't get media attention on this type of contracts.
Well, I was thinking in terms of press releases or something of that nature to get the ball rolling.
I actually just sent an email to our PIO, public information officer, to see if we can work together. There's the health department has its own PIO, and then there's the countywide PIO. So we're gonna see what we can do in terms of press releases and stuff.
Please don't get me started on talking heads, the county PIOs, okay? We need grassroots people who are knowledgeable about the subject, who can communicate with the community as a whole, okay? Yeah, I'm trained as a PIO in emergency situations.
Yeah, no.
I am concerned about the quality of information that gets out there, and particularly on this subject, because this, to me, is critical to the community as a whole.
Yeah, and working with our PIO, we would be crafting the messages, but accessing the contacts through our PIO. Their media, they have more contact with media. We will be doing our own campaigns utilizing social media, website, groups that we have joined, several groups on Facebook, for instance. There are different ways that we can do. I've done this type of campaign before like I said, in my previous life, including just mass mailers that we've done, flyers in English and Spanish, But it is something that we can work on, and we can report at the next meeting on our progress in rolling out. Also, the timing for it, because we are on a transition period, we don't want to, there are messages that we can start now because certain things are not changing, but there are messages that we need to time for when the new contract goes into implementation. But we will definitely, we put in some work in that area.
A follow-up would be very much appreciated.
Will do. Thank you.
Teresa, I have some questions. First off, I appreciate the concept of having a stakeholder meeting. Do you happen to have any timing on when that first meeting will be?
No, since the contract was just approved yesterday, we are going to be meeting internally to start to put some dates, including the meeting with the stakeholder. Officially, the contract is in effect upon execution, which it will take about a week. So we're going to be working in the next week or so to start lining up some days. We need to start reaching out for possible dates, like the hospitals. We'll have to see when everybody's available so we can see we can do them as a group instead of individually with each hospital. It would be better for us to do it as a group, I think.
So the point of that would be to go through the contract, answer any questions, provide any clarifications.
Yes.
Okay. A couple other things I have is the timing for the enhancements. Obviously, we just went through kind of what those are. Is it anticipated that those will all be effective February 1st?
Not all of them. For example, the nurse advice line, and they need to work with County Com because of the access to the CAD. There's a couple of others. Rapid call, I think, is one of them. There are two, and I might be getting them mixed up, but I think one is rapid call that is available to the hospitals. It would be a matter of the hospitals, wanting to implement it or not. As Kimberly reported, the implementation of the type 3 ambulances, it was going to be gradual. There will be a number of type 3 ambulances. We don't know the number right now because during the transition, they're going through the acquisition process of the equipment. We will know there's a deadline by which they have, in the transition plan and the milestones that we identified, there's a deadline by which they have to give us their fleet plan, the final fleet plan that will be into effect on February 1st. And so it will be then that we'll know exactly how many of each type there will be. We'll know the miles because they're not required to provide all new equipment. We'll have a list that shows that their fleet, the ones that are new, find how many are type 3, but also of the ones that are used, how many had the mileage, because there's also a cap. They cannot exceed a certain number of miles for the ambulances at the implementation time. I'm trying to think of other things that they need to be phased in, but I've given you a few examples, so there may be others, but those are the ones that I can think of off the top of my head.
Okay, so the folks that I represent, obviously there's some questions, and a lot of it will likely come out in the details, but just to kind of give you an oversight is BLS ambulance obviously new to our system, and how that would integrate with our ALS providers and what that looks like. So some of those details we'll need to kind of hammer into, as well as the policies behind that. So I would assume that we're going to see some policy updates and some anticipation of policy changes with regards to the BLS ambulance implementation.
Thank you for bringing that up because it was brought up at CCC. And so yes, so the plan is to, because that is, you're right, is new to our system. So we will need to work on those. And that is the advantage of us having that transition period. During that transition period, our goal is to work closely with the fire agencies so that we can craft the policies, see how they work and monitor things. And once they're implemented, we will monitor to make sure, what works, what doesn't work, if we need to go back and, repolish or do whatever we need to do. But yeah, during that transition period, which will start pretty much immediately, we will start working on those policies and engaging the stakeholders for input on those policies.
Okay, and it's not just the day-to-day stuff, it's also the special events, because in the agreement, it does talk about utilizing BLS ambulances for special events.
Right.
And, how are we going to mitigate the impacts to the ALS fire resources that may be impacted with that additional need? So those type of things. One thing I didn't see in the agreement and was a bit alarming to me because it's always been a mantra of the EMS agency is closest ambulance response. So it seemed like that was, I wouldn't say discredited, but it just wasn't in the agreement. So how are we dealing with that? And this would probably be something we can talk about during the implementation stakeholder meetings, but how is that concept still prevalent in the county, or is that something that we've somewhat discarded? So
I don't think it would be something that was discarded, but I don't know the new contract, very well yet. And I can't think of any section that specifically right now that talks about that. But I think it's best for us to talk about it during the meetings that we will have. But at least it gives me a topic to add to the things that we need to look to cover during the meetings that we
yeah, I
have
think
with
it
you.
just affects those folks that have the orange and the red areas, I guess, as soon as possible areas, if there are closer resources available to them. Being that it seems like automatic aid has now been taken out of the agreement. We're relying mainly on mutual aid, which is fine. But there's some ramifications of that we want to make sure that the folks that we're serving have some insight into that. The last two things I have for you is a lot of conversations in there about liquidated damages. And I'm not anticipating to see that, but something that I'm interested in is where do those funds go once they are paid? How does that help the people that are actually affected by the substandard service that they received? So those are the type of concepts I'm looking for. And then the final one is the 911 nurse. I think it's an interesting concept. I think a lot of the policy piece is going to be critical and the timing of it. When does that happen? Is that something that the first responders are somehow initiating, or is that completely through the contract even before we get there? Are we even dispatched? Those type of things, I'm kind of interested in how that's going to work.
And because it's not a program, the nurse advice line is not a program that is going to be implemented on day one. It is one that we need to work into implementing, and partly because it's a big conversation with County Com, right? And so all of those things, what our goal is to work with the stakeholders as we develop that program in making sure that we answer all of those questions as we move forward. Our plan in developing this contract, these contracts by nature, they're not flexible. They're very rigid. And so we worked very hard at creating some of that flexibility. There were versions of our agreement that got kicked back. Even when we first developed the scope of work, they was put out for public comment. Even then, we had the state already tell us that we couldn't include certain things in the contract. And so we found different ways in which we try to maintain that flexibility without locking us into anything specific. So it is one of the things, in nurse advice line, we couldn't develop, we needed to not try to develop the program because then it would hold us to it in the contract. And then amending those contracts is more difficult. So the way that we left it is open, that we will develop that it is available and may be implemented. It allows us the freedom to create the program that is going to work for our system.
No, I appreciate that. And just to kind of caveat onto Mr. Robbins' comments, those features that are delayed, we may want to quell the announcement of those, because I think, people are going to have an expectation that they're here, and if they're not, especially for an extended period of time, as you work through whatever challenges that implementation may have, we may want to be careful with that. So thank you.
Yeah, announcing or including in the presentation to the board and to this body the availability of the nurse advice line. It is for these audiences, not for the public's consumption. For the public, we will be more strategic in the education, the materials that we create.
I understand. I just realized this is a public meeting. So
It is a public meeting, but it is not well attended by members of the public. But it is also mentioning that these are features that, and we did explain that they're not going to be available on day one of the agreement.
Okay. Teresa, just one question. I didn't see how this new contract would impact the rates for the consumer.
Yes, the rates are increasing by 25%.
Ooh.
Yeah, when we look around in different jurisdictions, it is not a high increase in comparison. So it is in line with what we're seeing across the state in other parts. Mhm.
Is the agreement public? Could we read the agreement?
So the agreement becomes public once it's executed and it'll be posted. Our goal is to send it to those in our distribution list, the committee, at least the link to it. And making, hospital leadership aware of it, different stakeholders in the system.
Ms. Spencer, it was available yesterday. If you look at the Board of Supervisors packet, it was in there.
Oh, okay, great.
Yeah. Oh, yeah, that's one place where you would see it. But you would see the unsigned copy. So that's why what we will release is the fully executed agreement.
Will, I had a couple questions, if I may. First, Will, you probably be able to answer this. When do you think we'll be privy to a deployment plan?
As far as the main deployment plan, we'll work with the EMS agency to get that out to the stakeholders. I can tell you that we're working on staffing BLS ambulances immediately, with the first one going into the system fully August, then September, third one before the start of the contract for sure. Along with the start of the contract will be the additional unit hours, which I apologize, I don't have the exact number, but we're moving from a peak of 19 to 24.
Okay, and in the presentation, it mentioned the dispatch services. Is there any plans on moving dispatch back to county comm rather than having a separate venue?
No, at this time, the sort of parameters of what we did was to have a standalone dispatch center currently, with the backup center being available for us at county comm still.
Okay, and then in the presentation, it alluded to a statement in there. It says if it's founded that there's an inequity of response times, that the EOA provider will be on the hook to be able to address those issues. And this is more of a statement than a question, if we're concerned about inequity of response times, then why does the county have separate response zones, like 8, 12, 16? So I'm curious, what would we identify as inequity?
I can answer that. In terms of the different response times depending on the area of the county, we have to take into account how long it takes to drive to a location. So that's part of it. And in some cases, there's also accessibility issues, as you know. In terms of the equity issue, we do that now. Every month, Kimberly, can I put you on the spot again? Every month, Kimberly looks over the data in the contract compliance working group. They review the data of the responses to certain communities within its zone, if you will. Those do not have response time requirements, as they do the yellow, green, red zones. But we do look at them with putting things into perspective of the fact that they have very few calls. So applying the 90th percentile would be unfair. But we are looking to make sure that the areas are not underserved. Kimberly, could you expand on that?
Yeah, so we've brought, I think we've brought South County and North County. So we started working on looking at the South County jurisdictions. So, because if you look at what is now called the yellow zone, that includes a lot of places in North County and also in South County. So maybe I'm just coming up with, overall, yellow might look good, but if you're looking at it in specific zones that fall within the yellow zone, then we're trying to see, well, what if, I don't know, a certain city or community was they were almost never on time to those calls. So that's what we started doing with South County, and then we started doing it with North County. And right now we're doing North County on an annual basis because the call volume in each community in North County is so small, like within a year, Moss Landing might have, I don't know, 30 calls. So, I mean, like statistically, one call could throw that off and it would look really bad. So we're trying to look at what makes sense. And then with South County, same thing, we're doing it biannually. So like, for instance, King City within 6 months has about 350 calls. And so then we hold it up against what the compliance standard is, even though currently and even after AMR will not be held to a compliance standard at the community level. In the new agreement, it will show if we see that a certain area within a zone is falling and then there's not equity in response, then they have to have a strategy to try and fix that.
And if I may add to that, because it is a feature of the current agreement that is working. I remember years ago, the yellow zone was chronically under compliance. But working with AMR and looking at the data more closely, including the way in which Kimberly just described, worked because the response times have improved. And it's also credited to other improvements in the system. So we wanted to make sure that that very feature in the current contract, that it was carried over into the new contract.
Thank you. And then the last one, and you can either take this as a question or a statement. So through the process and when we got to the presentation phase, we reached out to the agency to ask if we could come to the presentation of the ones that turned in the proposals. And we were told that we could not attend and that it was just an informational meeting. But if you reviewed the succession of the RFP, there's also a panel of reviewers that were established. And even according to the Board of Supervisors report that you gave yesterday, it said that there's a panel of reviewers that included stakeholders. And I contacted the contracting office to basically sunlight who the panel was. And I got a letter back saying that that wasn't for public information, that they didn't need to disclose that. But you can either ask or answer my question or just take it as a statement. But, I believe that the fire agencies and the people that sit on the EMCC committee and the hospitals had a right to be on the panel of reviewers. And then just surveying local fire agencies and some city government officials, nobody said that they were part of the panel. So I'm curious, are you able to release on who was on that panel, or maybe moving forward that we can maybe reassess it? In my humble opinion, the people that make up the EMCC committee would make a great panel to review and approve an RFP.
Thank you for bringing that up, because I think it's one of the, it is a difficult position for the EMS agency to be in, because we want participation from our stakeholders as much as possible. We have to play by the rules of the game. As I've mentioned before, the RFP process for ambulance contracts it has strict oversight, not only by the state, but also by county council and contracts purchasing. We don't make any of the rules for that. We just follow them. And so for us, it's important to stay within the rules. There are certain things. We had more opportunity for input, for example, during the pre-proposal phase, when we released the RFP for public comment. When we released the scope of work for public comment, and we held the different meetings that we held. That was our opportunity to really get that input. Once the RFP is released, and this is not unique necessarily to the ambulance contract, but once this is actually my experience in handling different RFPs for the county. Once the RFP is released, then there's less communication. You cannot communicate with potential proposals, for example. You cannot communicate directly with key stakeholders that may, be impacted by that RFP. And the pre-bidders conference was a public meeting that everybody could attend. The meeting where the proposers gave a presentation to the panel was not an open meeting, and that's not a rule that I made. That was a rule, that's a county rule, and that's a contracts purchasing rule. So we had to follow that rule. We would have invited everybody if it was up to us. As far as releasing names of the peer review panel, I would have to refer you to contracts purchasing and county council, because had we been able to release that, we probably would have included that on our presentation to the Board of Supervisors. But because we were not able to disclose those, we didn't. So we are open and transparent as much as we can, and I think that we've shown that how transparent we want to be at these meetings. You know, we have told you when we've made a mistake, we have told you when things haven't gone right on our part. But when it comes to formal processes like the RFP, and for us, it was critical that we would be successful in this RFP. So we had to make sure that we followed the rules that the state has for these processes, as well as the county rules and contracts purchasing. I believe if they're not rules, there are standards that are followed across the board for public entities like, you know, county government.
Yeah, and just to follow up, I did contact the Office for the Contracting and Purchasing, and they said that this doesn't fall under the Freedom of Information Act. And so they responded back with the county council's input and CC to them. But again, I guess it circles back to my original question of how can we make a statement of the panel of reviewers were made up of stakeholders when there might or may have not had stakeholders in the system part of it.
And for the answer to that question, unfortunately, I do have to refer you to contracts and purchasing because, and I don't know if you noticed that during the RFP process, any and all communication related to the RFP could not come to us. It had to go to contracts purchasing because the process is protected to make sure that there's no undue influence into those processes. And so unfortunately, I have not been told that it's an information that we could release because it's still under the control of contracts and purchasing. Any question related to that process, then I unfortunately, I have to refer you to contracts purchasing and county council.
Yeah, and please don't take this as, in my humble opinion, right? And I speak on my behalf, not of my agency or the other fire agencies. Whoever this panel was, I think they made the appropriate choice. So congratulations, Will, Ben, Rachel, and all the staff at AMR. So thank you.
Thank you, Chief. And I hope you understand our position in the fact that we are not able to give you the answers that you want.
No, I understand. Thank you.
A whole different. You got it. Basically, when I've sat on a review board, it's been for a county that I had no impact on. And I was a neutral observer and trying to make an opinion not based on what I knew about my own county. That was my experience anyway.
Any other questions about item 7? Okay. Moving on to item 8, announcements of the good announcements for the good of the year.
I think we're coming back to.
Oh, pardon me. Yeah, the video. Sorry.
Okay. Do you want to retry the video?
Yes, go ahead.
Okay, I'm gonna try to share again. Give it a second. Let me know, just let me know if you're getting reverberation still, if there's a sound issue, and I can try to rework it, but hopefully this works.
Monterey County 911, where is the emergency?
There's a shootout. I need you to come immediately. Has someone been shot? I don't know. I'm inside and there's gunshots going everywhere. Okay, sir, have you only heard gunshots? They're flying past my house, like right now. This is happening.
At 5:57 p.m. on March 3rd, 2024, Monterey County's Emergency Communications Department received several 911 distress calls from callers in the vicinity of a drive-by shooting. According to the callers, multiple people have been shot and appear to be seriously injured. EMS ambulance dispatch is transferred to American Medical Response's EMS Dispatch Center, which has already begun to receive radio communication from a unit close to the scene.
Copy, can I get the nature of all this?
The initial incident triggered the Monterey County EMS System's multi-casualty incident response. Coordination began
Sorry, hang on.
immediately.
Just finishing a Zoom working. Go ahead.
TV's been firing that somebody was shot. Sounds like 4 was hit. Can you just let the deal up? Abram, do you need a third ambulance?
Dispatchers had to gather as much information as they could to relay to the hospitals and to the EMS providers. Was the scene secure? How many patients were injured? How critical were their injuries? Were there sufficient resources being sent to the scene? How long would it take for the ambulances to get there? How many patients would the hospitals be able to handle?
The incident occurred in King City, a small suburban community in District 3 of Monterey County. Law enforcement officers from King City, Gonzales, Soledad, Greenfield, and the Monterey County Sheriff's Department are dispatched to the scene of the shooting. Within 2 minutes of the call, American Medical Response dispatches 3 ambulances and a field supervisor. Units from King City Volunteer Fire Department and South Monterey County Fire Protection District are mobilized. American Medical Response Medic 26 is the first unit to arrive at the scene. Paramedic Christian Gutierrez and his partner, EMT Alex Oliveira, begin triaging the wounded.
I was thinking it would be maybe 1 patient, 2 patients. I had no idea it would be the 11 patients that ended up being shot that day.
It looks like it is critical. You need additional resource ambulance for your response to the
I have 4 gun ambulances en route.
It was just a chaotic scene, especially being the first one there and by myself. But once you start seeing the people that got injured, the people that weren't, we separated them, and then you can actually start counting the patients. And I remember requesting the resources on scene too, checking in to see where my other units were coming from.
How far out is my next ambulance?
Estimating how much time I have to work and get everything done. And I remember just thinking to myself, like, I'm the only paramedic here, like, it's my job to get this whole thing under control. I was very nervous, but in the moment I was just locked in and I knew what to do and what had to get done. So that's what we did.
The next arriving ambulance is Medic 47. They assist with triage and begin treating a young patient with multiple gunshot wounds.
We've got multiple GSWs. I've got a critical right here and right there. Why don't you start with that one and then take IC and start you guys forward for triage.
The goal of triage is to recognize the sickest patients as quick as possible so they can be transported to receive care from the hospital. Patients with serious and life-threatening injuries are the highest priority. Those with non-life-threatening injuries come next. In mass casualty incidents, the goal is to save as many people as possible.
My name is Andrew Fife. I'm a paramedic. I was on AMR Medic 47 on the day of the King City shooting. Once the 3rd medic got on scene, we made a game plan of triaging the patients and getting the most critical out first. From there, we quickly transitioned to a patient who had multiple gunshot wounds, loaded her on our gurney, and started to load her into the ambulance. I had a paramedic intern, a student who was with me. The scene was extremely overwhelming. What I wanted her to see was how to manage that many patients and emotions and to keep it under control. And she did very well. She was able to focus on the patients we had at that time and give them the appropriate treatment that they needed. It was a perfect storm of resources and units available for a terrible time.
Medic 25 was the next ambulance to arrive at the scene. They were assigned a critically injured patient with several life-threatening injuries. Fearing that their patient would not survive the 40-minute drive to Natividad, paramedic Cameron Silber arranged to meet a medevac helicopter at the closest hospital, Mee Memorial, which was less than a mile away.
It was a very short distance from the scene to Mee Memorial, less than a 5-minute transport because it happened just down the road and King City's very small. The turnover was really quickly, but when you're actually in the ambulance and you're actually working on a patient and working on a scene like that, time just feels really drawn out. What was a 5-minute transport felt like 30 minutes with the patient and an ultimate eternity in treatment.
As the sun begins to dip below the horizon, CalStar 5 arrives to meet Medic 25 at Mee Memorial.
Turnover to the helicopter was very smooth and very quick. We stood by for a minimal amount of time while they landed, entered our ambulance. We gave a handoff report, continuity of treatment, and helped them load the helicopter.
In addition to the patients found at the scene of the shooting, several patients drive themselves to Mee Memorial to seek medical care for their injuries.
When multiple patients leave the scene to go somewhere else, in this case, the closest hospital, the mass casualty incident spreads to a second site. Patients were now at 2 different locations, which meant that EMS resources had to be divided and sent to both locations.
It is the specialized services of a trauma center that are often needed for patients with gunshot wounds. The ED staff at Mee Memorial are capable of excellent care. However, Mee Memorial is not a trauma center. Our closest trauma center in Monterey County is Natividad in Salinas. Therefore, the highest priority for care for these patients is in stabilizing them and transporting them to Natividad.
With multiple patients arriving at the nearby hospital, some of the EMS units responding to the scene of the shooting are diverted to Mee Memorial. After handing off their patient to the CalStar team, the crew of Medic 25 joins Medic 38 and an ambulance crew from U.S. Army military base Fort Hunter Liggett to assist with the care and transport of patients to the county's trauma center. Patients requiring life-saving procedures, such as placement of a breathing tube or emergency treatment for a collapsed lung, receive those procedures in the emergency department prior to transport. As the emergency department team stabilizes patients and the EMS crews prepare patients for transport, hospitals communicate their ability to accept patients through the county's ReadyNet emergency communications system.
The use of ReadyNet facilitates sharing information between hospitals and EMS dispatch. The hospitals are able to share information on how many patients they can handle during a large incident. The EMS dispatch center is then able to relay that information to EMS providers that are in the field. The county's adult trauma center, Natividad, was able to accommodate all the patients from the King City incident that needed a trauma center.
A total of 7 patients were transported by ground or air to Natividad, the county's trauma center. AMR Medic 26 and Medic 47 transported patients directly from the scene of the incident. Medic 25, Medic 38, Fort Hunter Liggett Medic 8869, and the CalStar Medevac helicopter transported patients from Mee Memorial to Natividad. Some units transported more than 1 patient.
You can send a career to Mee Memorial. I'll be getting up to Natividad.
19-year-old male coming from King City, chief complaint, multiple GSWs to the abdomen. Blood pressure did improve after 1 liter normal saline, 1 gram of TXA. Blood pressure is 60/40, oxygen 94 on room air, heart rate 50 sinus.
Thank you.
Thank you. You guys ready? Ready. On 3, 1, 2, 3. Sir, can you hear me? Okay. Airways intact. Can you open up your mouth for me? Good job.
1 plus radial pulse.
Open your
Radial
eyes.
pulse.
16 to the left DC. Pupils, radioactive.
18 to the right.
Peyton.
Seems like multiple gunshot wound to the anterior abdomen. He's hypotensive. He has peritonitis. He's gonna go to the OR.
I'm sorry. There's a second GSW that just arrived. She's pale, diaphoretic, and hypotensive. Can you come see her?
Sure. I'll be right over.
Thank you.
let's call for MTP, get the blood going, and let's get him ready to go to the OR. Can you please call my backup surgeon in? Hello? Hello, Dr. Tran. Can you let me know what's going on?
The emergency department and trauma teams at Natividad continue to assess and treat the injured as additional patients arrive. Backup surgical teams respond to the hospital. Patients are taken to the operating room as needed, while others are stabilized and admitted to the hospital.
I was a trauma surgeon on call that day, and we got a ring down stating that we will receive several patients, unknown number from King City, and there was a mass shooting at King City. Our first patient arrived roughly 15 minutes after the ring down, and the patient was critically injured, requiring an operation. So I call in my trauma backup surgeon to come in and help, knowing that we will receive several more. And at that time, we received more information from EMS stating that the second patient will also be quite sick, currently receiving blood from Me Memorial. So at that point, I head up to the operating room, and my trauma backup surgeon already arrived to the hospital within the next 15 minutes. So she was able to take the second patient to the operating room, and within the span of 30 to 40 minutes, we received the rest of the patients.
On arrival, it was managed chaos, as the emergency department almost always is. We relied on open communication and frequent reassessment. As you can imagine, there were abnormal vital signs to deal with, bleeding, pain. Shortly after the patients arrived, there was then family, both calling and in the lobby, lots of heightened anxiety. We had several people come down and help us out from other departments, both with transportation and also with our needs in the emergency department. At least one patient needed to be transported back from the CT scanner emergently to receive a breathing tube and undergo several life-saving procedures. It made me feel good to have skills that were needed. It made me feel good to be available on that day. But overall, it just reinforced how much I love my job. I love to be there for people when they need it, and they needed it that day.
Good morning.
Good morning, Eddie. How are you?
I'm doing a lot better this morning, thank you.
So yesterday you had surgery. I just want to make sure everything's going okay this morning. The pain's under control.
Yeah.
And
This is my mom, Sylvia, Irene, and Kristen.
hi, nice meeting you.
Nice meeting you.
He's doing very, very well. Do you have any questions for us?
How long do you think rehab take?
Well, that all depends on how you do. It takes, a couple of days to go for a week. So the more you work with physical therapy, it will strengthen your muscles. And if your pain is under control, then you can go home with your family.
The patients and families affected that day continue to recover, as does the community and the many professionals who work together to treat the injured and to save as many lives as possible.
An EMS system needs to be more than just a collection of agencies and individuals. An organized and efficient response to an incident like this doesn't just happen. The Monterey County EMS Agency develops protocols, participates in training, reviews cases, and works with all of the organizations, hospitals, and people involved in EMS throughout the county. We prepare so that we are prepared, and so that the system and its providers are ready when the call comes in.
The King City incident was both tragic and traumatic. Our hearts go out to the victims, their families, and the community. We extend our gratitude to the agencies, hospitals, and professionals who came together and carried out their roles with an exceptional level of skill and proficiency. Their efforts are worthy of the highest level of recognition and appreciation.
Thank you all. I'm gonna head back to the room.
Thank you, Dr. Burley. So I get moving on to announcements for the good of the order. Any member of the committee may make announcements or comments. The EMCC may not discuss or take any action on any item raised during announcements, except to decide whether to take or whether to place the matter on a subsequent agenda. Pardon me. Susan?
Hi, it's Susan Duke, Base Hospital Coordinator for CHOMP. I had a concern and then a possible request regarding communication system testing. Back in March for ReadyNet, CHOMP had a fallout of about 2 weeks of consecutive ReadyNet system checks. And then, was not aware of it until April, like Kim was saying, I guess the dispatch center conducts the testing and then reports out at the end of the month for the previous month. And what I came to find out was it was probably, I think it was a login password issue that wasn't brought to my attention until, Kim had sent me the email in April. And so I'm wondering if, to identify these things earlier, is it possible that, maybe like with 3 consecutive fallouts, we get a notification that there may be a problem?
Kimberly?
Are we putting on, are we supposed to respond to announcements of the good of the order, or this for a future agenda item?
Hey, Kimberly, it's Michelle Kalinsky. Why don't we place this as a future agenda item? I've already forwarded an email. I think, it's really great that we have this system and we test, but as we watch things unfold nationally and wonder if people are getting our alerts or, hearing what the important information we're sending, it's critical that the agency has a pathway to follow up and to prevent extended misses or extended problems. So I think if we do identify, a couple misses or so, there's got to be a process in place, and we're going to have to develop that where AMR notifies the agency, and then either the agency calls or comes out. Does it somehow we troubleshoot so that all of us are operating these critical systems appropriately so we can be there to care for our community? So I think this should be placed on the agenda, and I think it's a critical item to look at.
Thank you.
Thank you.
All right, so next meeting of the EMCC will be held Wednesday, September 10th, 2025 at 10:30, and we'll adjourn. Thank you.
Thank you, everybody.